Hi, everyone. Thank you for joining so far. I'm just going to give it another 5 minutes. So we'll start at 8:05, just to give us some time for everyone to join. Okay, so that's 8:05. Zuhdi, are you okay with the slides just now?
I'm okay. Thank you, Zakaria. Hello, everyone. Can you hear me?
Yeah, I can hear you.
Brilliant. I don't think I figured out a way to share the slides with my video, so I will go with the slides on its own.
That's fine.
And I hope you can see them right now.
Let's have a look. Yeah, that's fine. That's great. Okay, so right. Just gonna have a look. Okay, right. So welcome everyone to today's session. We're going to be talking about the acute kidney injury and hyperkalemia. And this is another one of the Mind the Bleep urology sessions. So if we could move to the next slide, please. Right, so I'm just putting out a reminder here for everyone. We still have the 50% discount for CPD Me for those of you who can't be bothered putting their teaching on their portfolio every week. This is a really good application you can use, and it's designed for people who are registered with the GMC and the NMC and other healthcare professionals. And you can find it for free on your Android and iOS apps. So if you're interested in that, go ahead and use the QR code to get that discount from Mind the Bleep. And now I'm going to go ahead and hand over to Zuhdi, who is going to be talking about today's topic.
Oh, thank you, Zakaria. Hello, everyone. This is me. I'm one of the core surgical trainee in urology in University Hospital Ayr, part of West of Scotland. So maybe I should have a disclaimer to start with, that this talk will be focused from a urology perspective or a surgical trainee. I'm not here to teach you physiology or basic biochemistry. I would like you to take over a message where you would like to be more comfortable managing acute kidney injuries. So, to start with, simply an acute kidney injury or an AKI is a sudden deterioration in renal function. So, why it's important? Because it's common and it can lead to complications. And most importantly, early detection of an AKI is essential to prevent complications and hopefully achieve better results, such as early discharge from hospital or early recovery. A study in 2012 found that 30% or up to 30% of deaths from AKI can be preventable if early recognition was achieved. So whether you would like to be an obstetrician, gynecologist, surgeon, or an ITU intensivist, so this will be a common encounter during your daily life. And you will find it either incidentally if you are in a GP or primary care practice, performing some bloods, or in a post-operative settings, or if you are receiving annual patients in A&E or in the ward. So as a definition from a biochemical point of view, so there is a criteria indicating deterioration of kidney function, which is basically a rise in serum creatinine of 26 per 48 hours, and we're using the micromoles per liter units here, or a 50% or greater rise within 7 days. A clinical definition would be here a urine output falling to less than 0.5 mils per kilogram per hour for more than 6 hours. All right. I'll try to keep a scenario running with this presentation so you can be more clinically oriented. And I would like to invite you to imagine yourself being the SHO or the house officer, the doctor, looking after this patient across this presentation. So John is a 71-year-old gentleman who was admitted 4 days ago for an elective right total knee replacement. You were only reviewing the bloods on a post-operative day 3, and you found the eGFR coming down to 45, where it was more than 60, and it was completely normal. So obviously you can see there's a drop of the eGFR to less than 25%, and this basically indicates an acute kidney injury. So now, this is a common way for the acute kidney injury to be flagged up, incidentally on checking the bloods or post-operatively. Now, I will jump back to the presentation and please keep this scenario running in your mind. So, how patients will present with their acute kidney injury. Either you will find this clinically from like how they look. Unwell patients, they are drowsy, or they complained of weakness, nausea, presented to your GP practice. complaining of feeling sick or weak in the last few days. You've performed some bloods and then they came back showing an acute kidney injury, or they just basically are telling you that they are noticing they are not having enough urine output, or if they were in hospital settings, the nurses can flag this out, mostly in ITU or intensive care units. In biochemistry, you will notice as our scenario that urea is trending up. So here you can see in a few days, the urea is coming up, creatinine is trending up too, and the AGFR is dropping down. So obviously I put, this is a simulated or like a scenario for potassium, where showing you that potassium is normal, but then keep in mind that potassium is one of the most important electrolytes to be linked with AKI. So now going into the causes, I would like to define the causes as everyone or nearly every textbook do anatomically. So pre-renal, renal, and post-renal. Pre-renal means anything happens before reaching the kidney, and we are thinking here from blood supply point of view. You would think other hypovolemia, decreased cardiac output, so decreased blood supply. And just remember, we are discussing an acute kidney injury, so conditions such as renal artery stenosis are not considered the common cause, as this will mostly lead to chronic kidney disease. In acute kidney settings, just think about decreased blood output going to the kidney in acute settings. Other hypovolemic shocks, such as in bleeding, or maybe dehydration, or maybe someone who sustained a heart attack leading to heart failure and decreased cardiac output. Now, renal, think with any possible cause can happen in the kidney. This can be like infective or inflammatory or whatsoever, like can be nephrotoxic drugs, interstitial nephritis, or inflammatory like rheumatoid causes, any insult to the kidney originating from the kidney itself. And when you think that, think about the nephron as the main structure contributing to the kidney function. Now, post-renal, this is my nearly daily job, where most patients with AKI I meet have post-renal causes. And that's why I do urology, to hopefully help dealing with such patients. So this is the least common cause and most likely come from obstructive uropathy. Obstructive uropathy is mainly any decreased urinary output from the kidney due to an obstruction. Can be stone, as you see in this illustration, stone just sitting at the pelvic ureteric junction of the ureter, obstructing this kidney, and going down can be ureteric stricture or external pressure on ureters from maybe a tumor, or urinary retention from enlarged prostate, or maybe someone constipated or unwell with significant illness. So to sum up, causes are pre-renal, renal, and post-renal. And this is something as a medical student or a foundation doctor, you need to keep in mind while assessing and managing the patients, because knowing the cause is basically your key to the right management. So this slide is very busy, and my take-home message from this, that just to know which groups are usually at increased risk to sustain an acute kidney injury. And this will completely make sense. Elderly people, any people with previous acute kidney injury or chronic kidney disease, people with sepsis or like neurological or cognitive impairment who got dementia, agitation, chronic other conditions such as heart failure, liver disease, diabetes. So all of this makes complete sense when you see acute kidney injury patients. It happens in vulnerable groups, people who are unwell, people who are comorbid, people who can't look after themselves. So, and this is another important key message, because you need to suspect where to find acute kidney injury or to prevent it. So if I have one of those patients who got like cancer or they are comorbid, I would think, how can I prevent them sustaining an acute kidney injury? And that can be from doing simple stuff. Maybe the first thing to do for you as a junior doctor, requesting routine bloods for them, or make sure they are hydrating. So again, why acute kidney injury is an important topic, because it can lead to possible significant complications. Electrolyte imbalance and hyperkalemia. Although hyperkalemia is part of the electrolyte imbalance, but you would find it mentioned separately as it's really significant and important to highlight. Especially it can lead to high mortality rates. So metabolic acidosis, volume overload, uremia, or chronic kidney disease. Obviously, an acute kidney injury or acute kidney insult can develop into a chronic kidney impairment or chronic kidney disease, and then an end-stage renal disease. So, stages. Whenever, like we mentioned, organ failure, in most organs, there will be some certain staging systems. And this will be usually supported by biochemical investigations. In acute kidney injuries, our main biochemical marker for staging is creatinine. So I know now in most hospitals or laboratory results, it's easy to look at the EGFR, the estimated glomerular filtration rate, where it just gives you a hint, especially if it's linked to people age or like gender or weight. So, but then creatinine will give you mainly the staging system we have. And I'm referring to my slides mainly to NICE guidelines, where acute kidney injury is staged into 3 stages. And that's based on the creatinine. It can be like 1.5 or more the normal or the baseline level, or it can be 2 or more or 3 or more. And the reason for this slide is for you to know that it's always like where you have mild, moderate, and severe. Management, the urgency of management is always different, and the settings of the management is different. So if I was in a GP setting where I received a patient who complained from like being weak or having like some nausea with no known etiology, and you've performed the bloods and you've seen that the creatinine went like 1.5 times the baseline, you can maybe counsel the patient on more hydrating more, obviously after you rule out the causes you are assuming that they are contributing to this acute kidney injury, and maybe review the patient in 72 hours. It can make a sense, especially people who were dehydrated after sustaining a gastroenteritis. Why? If the patient are unwell, or you were suspecting an acute kidney injury before their assessment, you might review this in 24 hours. And the reason, as we said, there is a big role for prevention or early detection of acute kidney injury. And the reason is, as we mentioned in the first slide, it can decrease mortality rates. And the rest 2 stages have the same like flow and algorithm, where you need just basically to know exactly how urgent you need to deal with your patients and how urgent you need to refer them to maybe hospital or to the corresponding team for management. So approaching patients with acute kidney injury should follow a system. And the system we use here is A to E. And that's, I would assume that you are familiar with this, assessing acute unwell patients. And basically it's for people who doesn't know, it's like where you go for airway and breathing and then circulation and D is like their neurological status, and E else other. And obviously, this is a comprehensive review. You should be slick. You should do this in 5 minutes, wherever like patients need some maybe slick review. But in patients who are completely unwell, you might end up needing 15 minutes and repeating this twice till you are till your patient is stabilized and you have a clue on what's happening. So, but then this is usually a common approach for patients who are in shock, sepsis, like having hypovolemic shock or cardiogenic shock. And those can all lead to AKI, and most likely pre-renal AKI. As you all know, in shock, most of the time you will have decreased blood supply, decreased perfusion rate, as the definition of shock stands for. You'll have decreased perfusion rate to the tissue, and that would contribute to pre-renal AKI. So bedside data. So imagine yourself assessing our orthopedic patient there. You would like to know the observations. Are they hypotensive? Do they have like a possible hypovolemia, being hypotensive and tachycardic? What about the urine output? Is there any fluid charts showing their intake and urine output? So are they not drinking enough? Is there like any urine output they produce in the last 6 or 12 hours? So, and then try to look at their catheters or tubings. So sometimes patients can have catheter draining, and the nurses might tell you, all right, this patient only had 200 mils in the last 6 or 12 hours, which is significantly less than they have. But then they can have a stoma and having high ileostomy output, contributing to more fluid losses. So always have a look at catheter tubing systems, NG tubes, whether they are producing more than usual or they are blocked. And then look at the drug charts. Nowadays, some hospitals are having electronic drug charts. Please don't forget to look at them, as I nearly like meet on a daily basis junior doctors not addressing electronic drug charts. So try to collect all the data you have from bedside and then proceed with simple investigations. So simple investigations like urine dip. It can show you signs of infection, like having nitrites or leukocytes. It can show you some RBCs. RBCs can be a sign of basically having some sort of severe nephritis or like nephritic syndrome, or can be present in renal colic, kidney stones, bladder stones, or maybe an obstructive or causes from possible tumors either in the ureter or in the bladder. But they are not specific, but they can be sensitive, showing that there is some sort of inflammatory process happening there. Bladder scan. So it's a simple bedside procedure where the nurses can perform. I would usually call for junior doctors to do the bladder scan themselves. The best way is to familiar yourself performing bladder scan when patients are more comfortable, or they are not significantly unwell, or they are not deteriorating rapidly. Try to familiarize yourself with such procedures when you have a good room of time and space, and you are in less stressful environments. So bladder scan can basically show you if patients are in retention or their bladder is empty. An empty bladder flows with an acute kidney injury of like pre-renal or renal causes, where the patient is not producing enough urine. While a bladder scan showing more than like half a liter or in a retention picture flows with the post-renal kidney. Obviously, men, as we grow older, we would suffer from bladder outlet obstruction, and that most likely from an enlarged prostate. Enlarged prostate can be either from benign or malignant etiologies. So, seeing a man who is like maybe more than 60 years old with an acute kidney injury and performing no bladder scanning is really a big mistake, which you would like not to do. Other scenarios where bladder scan is of quite big importance in patients who are receiving strong analgesia post, like big procedures or significant orthopedic trauma or having significant pain, because painkillers can lead to bladder atony and retention. And again, if your patient is significantly unwell, do your important testing, such as ABGs. That will show you a picture of the lactate, acidosis, what's the pH, VBGs. It can give you an idea of the bicarbonate if ABGs is difficult to obtain, and bloods, ECG, and as your HE assessment, carry on with your investigations needed. So back to the common scenario where our 71 years old John, who had his right total knee replacement 4 days ago, was just figured out to sustain an AKI with an EGFR dropping from more than 60 to 45. So as you were attending this presentation, you remember to do your E2E assessment, and it was unremarkable. He is comfortable in himself, sat up in his chair, nibbling some crisps, and he looks fine. It's just a biochemical result. But then you've looked at their observation chart, and it was stable. Obviously, there was no fluid chart, as John was an elective orthopedic patient where we had no concern. So, and the drug chart showed that he is on enoxaparin, post-operative prophylaxis, metformin, ramipril, bisoprolol, ibuprofen, paracetamol, codeine. Now, again, because you are acting well and trying to remember the causes of kidney injury, you've suspected an element of renal cause. Looking at the metformin, the ramipril, the and maybe the ibuprofen. Sorry. So metformin, ramipril, ibuprofen are all nephrotoxic medications. So, and I know it might be difficult for you as a medical student to try to appreciate which medications are nephrotoxic and which are maybe hepatotoxic. But this is something you will develop by time with experience. So don't worry and don't panic. So your plan was starting fluid charts, and that makes sense. There was no fluid charts. You will start there just to measure their intake and output. You will hold metformin, the ramipril, and the ibuprofen. And you started some slow IV fluid in case he's not drinking enough water. And that's what we will usually call like a challenge of fluid. And you've asked the nurses to perform urine dip and bladder scan, as they are simple, easy to obtain in the ward, and they are cost efficient. And you booked blood for next days. So for now, this is what you are expected to do as maybe a junior doctor on a ward over the weekend, having no senior. So you need to assess the patient, make sure they are stable, and then again, try to find out what are the possible causes. As the patient is a post-operative patient, you would assume like pre-renal or renal causes are common. But again, he's in orthopedics, having a significant surgery. Having strong analgesia might lead to some sort of retention, and that's why you're doing bladder scan. But then, working this way would make sure that you are not missing anything. And again, the reason is to avoid significant complication. So now back to what we should do in initial management. And again, as you can read, any SHO should be capable to organize most of this and follow a plan. And obviously, the most important thing is you should react to your initial assessment. So if the patient was septic, we need to address sepsis. If the patient was bleeding or in hypovolemic shock, you need to address that. But then, in general speaking, you should rehydrate the patient. And it's not always IV fluids. So IV fluids is essential, especially for patients who are not keeping up, but even encourage patients to drink plenty of water. Oral intake is important as IV fluids. Obviously, you are aiming to prescribe IV fluids for patients in case they are developing any nausea or if they are more sleepy because of their pain, being unwell in hospitals, and especially overnight where you would like to make sure that they are hydrated 24/7. Fluid charts, it's part of the diagnostic and monitoring data you would need. Omit nephrotoxic. Review the drug chart and make sure they don't have any medication that can cause AKI. If you don't know what medications can cause AKI, use the BNF application on your phone. It's really helpful. And maybe the first couple of times, you would expect yourself sitting by the drug chart and maybe looking up every medication. That's fine. This is how we learn. Catheter. It's something you would like to consider in the patients in retention. And basically, you should be able to put a catheter yourself without handing over this to like another colleague or nurses. Because if the patient is in retention with AKI, most likely the cause is retention. And that's an obstructive uropathy. So sticking a catheter is basically the treatment. A catheter can be for non-obstructive uropathy causes if the patient is acutely unwell with like metabolic acidosis, where you would like to review to monitor their urine output. And then obviously react to the blood, so correct the electrolytes. And again, mentioning electrolytes is potassium, our main important electrolyte. Antibiotics if there is an infection. So if you are suspecting an infection, and that's usually supported with the patient urine, like clinical status or urine dip or inflammatory markers, please have a low threshold to start antibiotics and try to start non-nephrotoxic antibiotics. So no one will blame you for starting antibiotics for suspected infection, but you would be blamed if you didn't start antibiotic for a patient having an infection and deteriorating next day. Imaging. So ultrasound scan, usually in the NHS settings, you won't find it out of hours. But then again, if you are overnight or over the weekend, you can book the patient for an ultrasound scan. Try to get ahead with that. It's always helpful with an AKI not responding to your management or very severe AKI where you are worried on an unwell patient to organize an ultrasound scan. Now, if you are suspecting an obstructive uropathy, or if your patient is septic or severely unwell, where you think an AKI is within a context of more a significant insult or disease, organize a CT-KUB. And the CT-KUB is without contrast. It's CT, kidney, uretary, bladder, without contrast. So it shouldn't cause any harm for your patient. And again, highlighting for who doesn't know from you that contrast, IV contrast we use during our imaging studies is nephrotoxic itself. So you'd see usually radiologists performing CT scan without contrast on patients who are sustaining chronic kidney disease or significant AKI. From a urology perspective, our preferred CT scan would be considered CT-KUB, and the reason is it can show stones better. And again, don't forget to organize bloods for next day. You would like to monitor and follow up your management, hopefully reflecting an improvement next day. And again, AKI is something worth to be mentioned in your handover for your colleagues and for the list. Follow-up, obviously, you need to follow up your patient's symptoms. If they had nausea, I would hope that you give them some like antiemetics, because then this is something important for them to be able to drink water. If they were in pain, you need to address their pain, but maybe with non-nephrotoxic medications. Remember, in our scenario, we've omitted the ibuprofen for our orthopedic shop. So maybe we should prescribe something else. And again, monitor their signs, what is happening for the blood pressure if they were hypertensive before. And again, as we said, follow their bloods next day or day after. Don't forget to discuss your management with your senior or other colleague. Make sure you are doing the right stuff and you didn't miss anything. And then refer to the appropriate team. And appropriate team can be renal, wherever like you have renal causes, or it can be like intensive care if you're having like severe and acutely unwell patient, maybe with metabolic acidosis and some other organ failure in addition to the acute kidney injury. And obviously you can refer to us urology if there is an obstructive uropathy. And I hope you're not referring a retention, as you should be able to put the catheter yourself. So back to our scenario, where we were assessing John, our orthopedic shop. So next day, you've organized the blood and it came back showing an eGFR of 43. So that's nearly static. I won't consider that a drop. His electrolytes are still normal. The post-void bladder scan is 70 ml, so he was not in retention. His urine depth is showing plus protein. So there is no signs of infection or maybe an inflammatory reason. We know from his drug chart, he is diabetic as he was on metformin. So finding protein may be something maybe expected to see. And looking at the fluid charts, you've seen that his 24 hours urine output was around 1.4 liters. And this is 50 mils per hour. This number on its own makes no sense. You need to know the patient weight. So if drone was 58 kilograms, that's 1 mil per kilogram per hour. If drone was like 70, that's less. And obviously, if drone was like 164 kilograms, that's half mil per hour. So my message here, you don't really need to calculate this accurately, but then you need to have a sense. Is my patient having more than half a mil? So you would like to have more than half mil per kilogram per hour. And if you're not having this, I would be worried. And it can be either from like the AKI itself or maybe dehydration. So you need to work hard to achieve some sort of improvement here. So you decided to continue with IV fluids as nearly the patient didn't show any improvement. The eGFR is static, but he was stable and there was no post-renal causes you identified and no infection causes. And you decided to carry on holding the nephrotoxic. And again, you requested bloods and the renal ultrasound for next day as he didn't improve. Now, back to our presentation. So I would like to make a pause here as we've nearly been talking for half an hour. So guys, this is what I usually try to explain to my fellow colleagues I teach usually. So there is a comfort zone, and you will find this comfort zone with any perspective in your life. Obviously, this is your medical or clinical comfort zone. So everything happens you are comfortable with is within your comfort zone. If you are a foundation doctor, you will find writing discharge letter lying within your comfort zone. Maybe having referrals lies on the edge. So if you are comfortable referring to general surgeons, that's in your comfort zone. But if you never referred to maybe psychiatry or neurosurgeons, that's outside your comfort zone. But then at least you know how to refer in a basic manner. I would like you to try to indulge AKI and hyperkalemia in your comfort zone. So I hope today the AKI and hyperkalemia topic are standing by the edge. But remember, later on, if you read more about it, if you address patients more about it, or if you discuss with your colleagues an unwell patient having AKI in your ward, you would try gradually to make your comfort zone including this in near future. And obviously there's some stuff which can be far from your comfort zone. But again, if you are part of the CPR or crash bleed, your comfort zone can grow and grow by time till it just become much more bigger, where you will be comfortable addressing everything. And this will happen with experience. So it will build up gradually. Be patient and be persistent. And I would advise using virtual and simulated training. And as a surgical trainee, this is a good way for, usually for us surgical trainee, to improve our experience, where you like to revise a step of a procedure in your mind before starting, and revise it again after finishing. What would you make different? And again, you can train it. You can do it on a simulating setting using simulated tissues or simulated machines. So mind your comfort zone and take care of yourself, just to be better in providing your care. So my next topic, which is just a few maybe slides, 5 minutes talk on hyperkalemia, which is very associated with AKI, acute kidney injury, leading to significant complications or maybe high mortality rates. So basically, remember, potassium is one of the important electrolytes in our body. Usually you would find it intracellular, and just remember the word high kin is just, this is like usually USMLE Kaplan like a sentence, having a friend called Ken and you're just saying hi to him. So high potassium inside. So and try to memorize this. Normal potassium is 3.5 to 5.3. If you didn't know this before attending this presentation, I would be happy if you leave with this information on its own. Normal potassium is from 3.5 to 5.3. And there is something called pseudo-hyperkalemia. Again, as we said, potassium is intracellular. So if that's the cell, and you will have the potassium here, if the cell ruptures, potassium can leak. So if you are withdrawing blood in very difficult patient to bleed, the sample can hemolyze, and the red blood cells can hemolyze, leaking potassium into the tube, and that will show false hyperkalemia. So that's why it's important to double check that this is not pseudo hyperkalemia. Obviously, if it was me assessing a patient for hyperkalemia, I would like first to know the patient and the clinical scenario. If you are having hyperkalemia with an acute kidney injury, try to have very high threshold to assume that this is pseudo hyperkalemia. Most likely, hyperkalemia will flow with acute kidney injury. So don't assume that this is a pseudo hyperkalemia. All right. So classification, again, it depends on the numbers. So this is why it's important to know this, and it's important to know this to triage your patients, because most of the time the lab will call you while you are performing another task or reviewing another unwell patient, telling you that the potassium is abnormal, being 5.5. And that's just slightly above the upper limit. So would you worry and leave your unwell patient and deal with that, or leave it once you are done? This is why it's important. For who you are being on call in maybe surgical or medical wards carrying the bleep, this is maybe something you've encountered, nurses or the labs calling you for hyperkalemia. And it will usually, you will receive this phone call while performing another task. So try to memorize this so you know how to triage your patient. And later on, you need to know how to classify your hyperkalemia. So a mild hyperkalemia is 5.5 to 5.9. So obviously, you need to review those patients. You need to address why this is happening, try to treat them as soon as you can, and prevent further deterioration. Moderate hyperkalemia is between 6 and 6.4. This needs urgent review and treatment. And obviously, you are requesting an ECG for all patients with hyperkalemia. And then severe hyperkalemia is more than 6.5. This is a life-threatening condition. If you have a hyperkalemia more than 6.5 or with ECG changes, this is a severe hyperkalemia where you need to triage it as high priority. Like this is your priority 1 patient to see. All right. So now speaking, so again, my message, if you are receiving the bleep of abnormal potassium, know the abnormal potassium level, and try to have a counter-attack reflex to ask the nurse who is bleeping you for hyperkalemia to perform an ECG on that patient till you walk in and review that patient. Obviously, this again flew with the virtual training. So if you just close your eyes and imagine the nurse calling you for hyperkalemia, you would tell her, thank you, I will come and review the patient, please do an ECG. So what would you see on an ECG? You would see signs of bradycardia, P waves being absent or PR prolongation, or any funny arrhythmias. You would see significantly peak T waves or retented T waves, or widened QRS complex, or fatal arrhythmias such as VT or ventricular fibrillation or ventricular tachycardia. You can see an ECG strip here showing maybe tented T wave. So you don't need to be a cardiologist to identify this. Familiarize yourself with ECGs. And again, as we said, try to familiarize yourself with ECG when you are comfortable, maybe reviewing very stable, comfortable patient with your senior colleague where you can have a look and discuss the ECG for more training opportunities, because the last thing you would like to do is carrying and holding up this ECG strip, assessing an unwell patient and then see nothing. So you can see here a tented T wave. The QR complex is not widened, it's just normal. And then I can't see any, like the P wave is faint, but it's still here. So the only finding I can see, I spot myself, is a tented T wave. I don't need to be a cardiologist. So with this, I can see hyperkalemia ECG changes. That's enough for me. I have hyperkalemia blood result and I have an ECG changes. So that will classify my patient as having severe hyperkalemia, despite the results. So if anyone have ECG changes, this is a life-threatening emergency condition which you need to address. So obviously, I'm referring to North Bristol guidelines, and I'm referring to them just to code this, to code the last sentence. If there is an acute changes of more than like 0.5 millimole in 6 to 12 hours, this might be significant. So if your patient like had a potassium of 4 in the morning, and for a different reason, you repeated their bloods in the evening to monitor their AKI, and their potassium came in the evening like at 4.7, that's potassium. So that's still within normal limits, but this is a significant raise. And then for that reason, you would like to address this AKI in more urgent matter. So back to our patient, John, who is 71 years old with diabetes, as we know from his metformin, hypertension, has his total knee replacement a few days ago. So you came after 7 days, once you finished your on-call, back to the ward, and you found up that he sustained wound infection, post-surgical site infection, and he was started on antibiotics. He had a normal ultrasound, but his AKI deteriorated. I believe this makes sense. He is a comorbid 71, and he was unlucky to sustain this complication. Having antibiotics, wound infection doesn't help an AKI settings. And suddenly, the nurses called you for a potassium of 6.2. Again, my take-home message: try to organize an ECG before you arrive at the patient. You would like to have triaging of the patient yourself. So once the nurses calls you, ask for the ECG, you plan to do an ECG, and then obviously you are doing always an A to E assessment, and you are still asking yourself, is that a pseudo hyperkalemia? But then again, because you know that John had AKI, you would assume it's not. So if John was someone who is like 25 or 30 years old, who had just walked into the hospital to have regular blood tests, and then he had normal bloods with no AKI and had hyperkalemia, maybe this is something you would consider, but not in this setting. All right, so you've done the ECG, you've seen the T10 waves, now you're gonna have like some sort of plan. The plan, I'm not planning to teach you this today, but you need to check your local guidelines. Every NHS trust will have local guidelines on the intranet or shared drive, where you need to familiarize yourself with those guidelines and try to hover across them when you are having free moments. And again, it's just building your comfort zone. The main idea treating hyperkalemia is you need to get rid of potassium and try to buy some time shifting potassium from extracellular to intracellular. So you are targeting the main cause to treat. So if they were like having an AKI, you are already managing their AKI. It can be with IV fluids or simple as having a catheter in a patient with retention. So hydrating your patient is something which completely makes sense. You will dilute their potassium, so you would use fluid without potassium. So Hartmann's is a favorite surgical fluid. It contains potassium. Every liter contains nearly 4 millimole. So another take-home message: don't use Hartmann's in patients with hyperkalemia. If your patient was already on Hartmann and that was prescribed by your consultant, feel free to cross it off. Cardiac stabilizer. So example, calcium gluconate. Some other trusts use another forms of like calcium gluconate or maybe fumarate. Basically, they will decrease the threshold of arrhythmias, and usually a drug like calcium gluconate can last from 60 to 90 minutes. So that will usually give you a good window to drop your potassium, the potassium levels to a more safer rhythm. So basically, cardiac stabilizers like calcium gluconate are not like a main treatment. They will just buy you more time. Insulin and dextrose, they will shift potassium from out to intracellular. And again, check your local guidelines. Usually there will be IV insulin and IV 50% dextrose. Giving subcutaneous insulin would help, but not in an acute setting. So you would try to, you are targeting the insulin intravenously. And that's why you need to give dextrose to avoid hypoglycemia. Salbutamol, again, it's one of the medication which help shifting the potassium from extracellular to intracellular. And calcium resonium is a potassium binder which the patient take orally, and that basically will help the patient bind the potassium from their GI tract and then defecate it. So If you are giving calcium resonium in a constipated patient, you would consider giving them laxatives. They need to open their bowels. And again, if this doesn't help your potassium going back into safer or normal levels, you need to consider dialysis. And obviously, this is a referral to renal doctor. So, long story short, if patient does, the best way for the patient to correct or to get rid of their potassium is either to pass urine or to open their bowels. If they are opening their bowels and passing urine, you have a way to get rid of your potassium. Otherwise, you need dialysis. To buy yourself a time, you can use some medication to shift the potassium from extracellular to intracellular. And again, don't forget using cardiac stabilizer in patients with moderate or severe hyperkalemia, or patient definitely with ECG changes. And again, please check your guidelines whenever you have like a moment. That will help you maybe knowing exactly where to find them, or you can download them to your account or to like your drive, where you can use them whenever you are in such a scenario. So that's me trying to address an AKI and hyperkalemia from a urologic perspective. Please feel free to ask any question. I hopefully will try to answer all. Thank you.
Thank you very much, Zuhdi. That was an excellent presentation, very informative. I'm just going to have a look. If anyone would like to pop a question in the chat box, and I'll relay them to Zuhdi. I've got one question here for you. So someone, Nicola White, was asking for you to clarify pseudo hyperkalemia in relation to AKI.
Oh, sorry. Yeah. So pseudo hyperkalemia is a term, as it says, like it's false hyperkalemia, where we would usually like assume that the results we had from the lab is wrong, mainly because of hemodialysis. Mainly because of hemolysis of the blood while being withdrawn from the patient. My key message was, if you have patient sustaining an AKI, don't consider pseudo hyperkalemia as a cause. Take any hyperkalemia in an AKI settings seriously as a true one. Obviously, you will send more blood. The blood bottles you send, they will come back to you within 1 hour or two to confirm that, but no one will blame you for managing the patient. Most likely, AKI and hyperkalemia are true concurrent conditions.
Okay, that's great. I hope that makes sense for you, Nicola. So there's another question here. At what EGFR do you rule out using iodinating contrast?
Usually, radiologists will have certain criteria. They usually try to avoid IV contrast for EGFR below 30. But then, guys, the thing here is not from a contrast or an AKI point of view. Is you'd like to put the full picture all together. Do we need the CT scan urgently? So if it was a CT scan for suspected cancer, the cancer will not grow in like a couple of days, or maybe even 3 or 4 or 5 days. You can delay it. While if you are performing a CT scan for someone who might just have ruptured aortic aneurysm, you won't really care about their EGFR or hyperkalemia. So try to put the picture all together. But then answering the long story, the long answer short, it's 30 is usually what's followed.
Great, okay, that makes sense. So there's another question here. Still not quite sure. So why is creatinine used as a diagnostic tool for AKI? EGFR is used for chronic kidney disease. Doesn't creatinine disregard the context of the patient in terms of age and sex, etc.?
Oh, yeah. So to be honest, this is a tough question for a surgical trainee. I'm not a physiologist. but I would assume that usually creatinine is more sensitive. So again, it's from mathematical point of view. You would see like a big change in creatinine with maybe sometimes a few change in the EGFR. So someone creatinine can move like from 50 to 60 without affecting their EGFR, especially if it was a normal EGFR. So, but then again, creatinine is sensitive and it can be an early detector. I would assume it's mainly from the mathematical reasons, just from how the formula is calculated.
Okay, and I think we have one more question. So someone asked, what is the role of diuretics in renal AKI?
So again, there is no role for diuretics as a treatment for AKI, but then they have a role in treating overloaded patients. So it's very common to see doctors, especially in ITU, prescribing diuretic for an overloaded patient sustaining an AKI. But the diuretic was not mainly for an AKI. It was for the AKI. It was for the overload. So if the patient having desaturation or significant pulmonary edema, you are giving a diuretic to basically to keep them alive, as you are following an algorithm of like ABCD. Obviously, their breathing is much more important than the kidney. So otherwise, you would intubate them. But then I think you would see this wrong practice, especially sometimes it used to be like given like from old maybe or like old trained doctors, where they used to give like IV diuretics to challenge the kidney and make it produce more urine. But then this, unfortunately, most of the time end up causing stress and overload and deterioration of the AKI. You don't give IV diuretics except the patient is overloaded. There is no role of IV diuretics in AKI.
Okay, that's great. There was just one more question. So any advice for pre-hospital clinicians like paramedics, etc.?
Sure. So basically, you would try again to think on the algorithm of A to E. So if the patient is having hypervolemic shock because of bleeding, stopping a bleeding point would help to keep the patient's circulation sustaining its volume as much as it can. So you can do a lot from point to stopping the bleeding. Trying to obtain a cannula and maybe starting some IV fluids as you would do in resuscitation, or like maybe if you are having a patient with sepsis, trying to identify like sepsis as a cause of maybe deterioration. So actually, I don't know, Zakaria, I do remember myself being part of the trauma team. Whenever we used to receive patients as part of the trauma calls, I think the main thing of our treatment would usually start with a good handover from paramedics. And I do really remember the faces and the names of the paramedics who used to deliver the best handover ever. And I think this is a good way to start with.
Great, thank you very much. I don't think we have any more questions at the moment, and that's us over time. So I'm probably going to go ahead, and if we move on to the next slide, I'll just conclude our presentation now. So thank you everyone for joining us. We've had a great attendance today, and the session was really good, in my opinion. So I hope it was useful to all of you. If you could all go ahead and use the QR code on this slide and fill in the feedback form, just so that we know what we did wrong and what could be better. That would be great. I'm going to pop the link to the feedback form in the chat box once we finish. I also note that a few of you have been asking for the slides as well, so I'm happy to send them your way. If you send us an email at the address on this slide, so urology@myonthableak.com, if you just send us an email asking for the slides, and I'm happy to send them across to all of you. And I hope that you can use that to your own use in the future. So be sure to join us next time as well. So we'll have a session on flank pain and renal colic next Thursday. So thank you very much, everyone. And I'll just go ahead and pop that link in the box now. Thank you, everyone. And I hope you have a good night. And thanks, Zuhdi, as well.
Thank you. My pleasure. Thank you, Zakaria. Thank you, everyone.
Thank you.
Thank you.